The president has declared the opioid epidemic a national emergency. Overdoses involving heroin and pharmaceutical opioids killed more people last year than guns or car accidents, nearly 100 a day. Is Hawaii part of this national epidemic? And are we still regarded as the crystal meth capital of the country? An important local update on deadly addictions. Tonight's live broadcast and live stream of Insights on PBS Hawaii start now.
Aloha and welcome to Insights on PBS Hawaii. I'm Laurie Yamada. So how many people in Hawaii are dying from drug overdoses? According to the National Center for Health Statistics, 179 people died of a drug overdose in Hawaii during the 12-month period ending March 2017. A little better than last year, but that's when 187 people died, still high. Hawaii, which saw a 4.3% decline, was among only 10 states with fewer drug overdose deaths year to year. Hawaii ranks relatively low among states for opioid poisoning fatality rates, coming in at 43rd. Yet we are almost at par with other states for drug poisoning fatalities as the leading cause of accidental deaths. Most drug fatalities in Hawaii are caused by illicit drug poisonings. 15 years ago, crystal meth was identified as the drug of choice in Hawaii. Today, the number of deaths attributed to ice has more than doubled. All right, we're going to get to our panel of experts, which includes both law enforcement and substance abuse care providers. We're going to hear their analysis of the statistics and learn what they believe to be at the heart of Hawaii's drug problems and the solutions that must be included. So we look forward to your participation in tonight's show. You can email, call, or tweet your questions, and you're going to find a live stream of this program at pbshawaii.org and on the PBS Hawaii Facebook page. All right, to our guest now. Ed Kubo is a state circuit court judge appointed in 2010. He is the presiding judge for Hawaii's drug court, mental health court, and the veterans treatment court. Now, these specialized courts supervise and oversee the treatment of hundreds of persons who are considered to be high risk for reoffending or who are non-compliant with probation due to addiction and or mental health issues. Alan Johnson is the president and CEO of Hinamauka, which has provided drug and alcohol treatment in Hawaii for 48 years. In addition to 20 years of service with Hinamauka, Mr. Johnson is chair of the Hawaii Substance Abuse Coalition, a hui of about 35 nonprofit treatment and prevention agencies throughout the state. Heather Lusk is the executive director of the Community Health Outreach Work to Prevent AIDS Project, also known as the CHOW Project. Now, this organization is dedicated to serving individuals and families and communities adversely affected by drug use through a participant-centered harm reduction approach. And Christopher Sloman is the Assistant Chief of Operations for the City and County of Honolulu Emergency Medical Services Division. He has more than 25 years of experience in fire and emergency services. As a former fire captain, paramedic, and flight medic, he has responded to more than 30,000 calls for emergency services. So thank you so much, all of you, for joining us. All of you so incredibly dedicated to helping the people in our community and dealing with problems such as this. And, you know, as I mentioned in the introduction, you know, it's been a while since I think we've really seen it prominent in the headlines as to how bad the drug situation is here in the islands. We're hearing, I think, a little bit more of it currently nationally. Whomever wants to jump in, you know, where are we at right now, and what have you seen happen over the past several years here in Hawaii?
I think we're starting to backslide as far as the drug use of ice is concerned. In the early 2000s, you know, we had a bad problem. We had town hall meetings almost every week in some place in this state. And I remember the cries of the parents, I remember the heartaches, I remember the kids getting in trouble, and we all came together. You know, not only law enforcement, but providers and the community and parents, and we were able to do things. But I think over the years, you can only keep that drumbeat up for so long before you start getting fatigue. And so I think either that or some form of complacency. And so the cries are not loud anymore. And what you're seeing is drug dealers, or at least as far as us judges, we're still seeing a high percentage of methamphetamine abusers who are committing crimes. And this is troubling because this is affecting the next generation beyond us. And so it's very concerning for me.
I think we have a slide our producer was mentioning from 2010, the increase that we've seen. We're going to show a couple of these slides here. And this in particular is interesting, not only the next generation that you're talking about, Judge Kuba, but also some of the other sectors and age groups that we haven't seen before. 50 plus, an increase. Females, an increase. What are you seeing out in the field? Your thoughts? Are you surprised by that at all?
No, I believe we're much more aware today that people are, that they have depression and anxiety, that they have injuries and wanting to do something about them. And certainly the Affordable Care Act really helped do that. That said, hey, you should get medical treatment for your untreated issues. But as people have been using alcohol, methamphetamine, opiates to address those issues rather than always going to see a doctor. And so now we're seeing them really come forward. I mean, methamphetamine is still, if you have a chronic condition of addiction, we really see huge numbers of methamphetamine and then alcohol and then a growing number of marijuana. But if you want to talk about abuse, and we've changed our talk too, we're not just saying you're really addicted, we're saying how about those who are abusing but aren't quite at the addiction level? And we've unearthed huge numbers of abusing, and now we're seeing it's opioid. It's opioid and marijuana. It's giant.
You know, we were talking.
And those are alarming.
Actually, go ahead, Heather.
I was going to say, for me, one of the biggest things of the past year was the Surgeon General's report on addiction. Almost 500-page report coming from the U.S. government. It's a groundbreaking report and really saying that addiction is a health issue and that we need to treat it as a chronic health issue. And so I think now having this roadmap, which is really our best evidence base moving forward, has really allowed, Hawaii, we were already trying to do this, but it's really allowing the evidence to say we need to treat addiction and substance use disorder as a health condition and have it treated within medical settings the same way.
Well, what's so tough too, I would think, is the funding for it, the bodies for it. We were talking earlier, Chris, about you know, EMS is stretched here in the islands. I don't think people quite realize some of the numbers and what you guys are dealing with day in and day out.
Yeah, well, I mean, it's not all related to, obviously,
right, just
we deal with everything, but yeah,
workload.
EMS overall is incredibly stressed, right? And I think we were talking earlier about we have 20 ambulances to cover the whole island, and you compare that to other similar populations, and we're at 2/3 of the staffing of other places. So when you compound that with all of the accidents, that may or may not be alcohol or drug related, the actual incidences of overdoses and those things, it just adds to the stress of that.
Speaking of some statistics, I think we have a couple other slides to get to. One, this is a pretty sobering number. I think it was talking about just how many prescriptions are written every year. And I got to admit, I wouldn't have expected it to be quite this high. I think we have a slide on that there. All told, about 500,000 prescriptions of oxycodone and hydrocodone just in the past year here in Hawaii. Does that number surprise you?
It does, because we're not seeing as many people in treatment as we thought, if it would be opioids being that high. But we had never thought to ask the question about methamphetamine and said, where did you start? Because years ago you started with marijuana and alcohol and now you're on methamphetamine. But when we started asking them, people started saying, I started with opioids and now I'm moving on to meth. And so that number is huge. And so now we're seeing the reports that say that there's enough pills for, that every man, women, and children in Hawaii could have 700 pills a year. Well, it's like, well, not everyone does. So who has that many? And where are they going? And what are they treating? Where are they getting them?
So why is that happening? I think we were talking earlier about, so happened to catch a New York Times article, and they described this has just been sort of building over decades of overprescribing, of more access to whether it be cheaper drugs, say heroin or whatnot, or maybe fentanyl. A lot of people talking about fentanyl because of the synthetic drug, because it's so incredibly potent. Does this, when you look back as to where we are today, do you see answers? Do you see reasons as to why we are in the crisis that we're in right now?
We know for sure, and they have names even. But there are certain pharmaceuticals who decided to a major marketing campaign that said that we think Americans have pain and you shouldn't have pain because we have something for you and it's non-addictive. And there was a huge marketing to all the physicians in the United States and the dentistry and all the field, and said, you need to prescribe unlimited to this because it's safe. And it turns out it wasn't safe. It was a great marketing campaign, but it really wasn't very safe. Yeah. And then we also had the deterioration of, especially rural America, of the breakdown of all the businesses, and then you had people out of work, and then people feeling trauma. And people said, hey, you can get it at your local store, and here's all you can have, and you can get as much as you want. And now we're trying to put the brakes on it, but it's really hard to change when it's a cultural shift now to say, stop that, slow down.
Yeah.
Judge, too, we brought up those statistics about 50 plus. A lot of the folks that you're dealing with, veterans, for example, some of them are hitting that point in their life or physically deteriorating enough where maybe for a period of time they were able to either resist or not get as, fall into that. But that's changing for some of these age groups.
Yeah, in fact, there's several people that I supervise who are from the Vietnam War, and they're well over 50. And also what we're seeing is at least an attitude also change. And what I'm feeling is occurring, to add to what Alan is saying, is that we've somehow conditioned ourselves to be so low in terms of the threshold of pain that we're so willing to take a pill to make it better, rather than how my father used to say, tough it out. And so I think the way life is today, it's more acceptable to take pills for various things, and I think that leads to the possibility of addiction.
Making it more acceptable socially, whether just seeing it and prescribing, that really does have an impact on people.
There's some data actually indicating that the narrative of illegal drugs are bad, but if they're prescribed, they're good, has actually contributed to this problem, because many folks said, well, my doctor prescribed this medication and I got 60, so it must be okay for me to take 60, even though maybe I only needed a week's worth. And then the dependence grows, so then the research says, well, if the dependence grows and we don't address the dependence and then they're cut off from those medications, then they come off into the street and get the street drugs. So we're seeing kind of these unintended consequences sometimes of well-meaning interventions like cutting somebody off, but then they go to the street to get that need met otherwise. So we're learning a lot more research is coming out about what's behind this epidemic, and what about the messaging, and why are people having a different message of prescription opioids versus heroin, when really kind of pharmacologically they're very similar.
I think we have a slide on that too, kind of showing some of the statistics and the numbers going up there, and you can see that right behind you here, there's a screen if you guys ever want to take a look. The illicit drugs obviously high, but still with prescription drugs as well as pain relievers still going up as well, prescription second highest. So that just kind of goes to show you that, graphically what part of the
what also happened is we just now have the data to know that opioids, of course, are very good for acute pain, and they're a wonderful thing for that. And so we're not saying all
Cancer
opioids are
treatment, for
bad.
example.
You break your
Yeah,
leg.
you have a surgery and you want to get all of that's really helpful. But now we know for chronic pain, it's not very effective, because we now know that the longer you're on it, the more sensitive to pain you become. So your pain actually is increased, not because the pain is there, but because the drug makes you feel like the pain is stronger. So now you need more opioids.
Interesting.
So the whole thing feeds on itself and just creates more problem.
I think we had I'm sorry, go ahead.
And then, I think doctors were used to seeing patients that are, this middle class, and it's mom and dad, and it's even grandma and grandpa. I've known them for all these years. Of course you need more opioids. Oh, you need more? I'll get you more, because you're not homeless. You're not living on the street, you're not a drug addict, but all of a sudden, surprise, you are a drug addict.
I think we have a couple more slides here just kind of showing the difference between 2009 and 2099 and 2009. I don't know if I jumped past that. Did I jump past that already? But it really is just, here you can take a look here. This is 1999. So this is admissions that we're seeing here. Not a whole lot. Hawaii's barely on the map, I believe. And then you just jump ahead 10 years and you see a pretty drastic difference, especially in Hawaii, as to the rate. And that just kind of goes to show you, what's been changing. Kristen, you were talking about, I wanted to kind of jump to this, you were talking about what you've seen elsewhere that you've worked as examples as to why this is so easy for whether it being the prescription drugs or illicit drugs, just coming into the country. You were working in Nevada, New Mexico, you said? You saw it firsthand. How big of a drug problem we have here.
Well, especially along the southern border, there's a huge drug problem. That's you have the corridor for all the trafficking.
Yeah. It's coming in easily.
It is. Well, I think they're doing a lot, and I think you've seen really the rise of meth specifically is as actions in law enforcement, I think, have made it more difficult for the illicit stuff to be imported into the country. You've seen the rise in meth because you don't need to import anything. You can make it here. And I think my personal opinion is you'll see an ebb and flow in the popularity and the use of meth as other things, if they're not addressed, as the availability or the cost of those fluctuates.
Speaking of cost, I think we had some numbers about how much it cost just this past year for treatment. Here in the state of Hawaii, I think it was close to $10 million was kind of the rough estimate. When you think about the amount of money that's being put in to dealing with this, as opposed to the amount of money for treatment, for the programs that will work and will help, what are your thoughts? No yelling aloud. Because you see how it works, and you're all fighting for it every year.
Well, all the research is saying that 5% of the people cost 50% of all the healthcare costs. I mean, that's huge. And those 5% are, of course, the elderly, those with chronic illness, and those with substance abuse and mental illness. So those are giant numbers. And here in Hawaii, they say our cost for healthcare is about $9 billion a year. And just figure the 5% of the people cost $4.5 billion. Those are giant numbers. And we're backloading it. We're treating people when you have severe chronic illness, a heart disease, and you have hypertension, you have diabetes, and a lot of these things started with substance abuse or mental health, untreated substance abuse, mental health, untreated depressions, untreated traumas, and if we were to front load it, the dollars are huge that could be saved, just giant.
Couple of questions. Oh, go ahead.
I'll just say also diverting, again, out of the criminal justice system. It costs about $50,000 a year to have someone at OCCC. And over half of the folks in OCCC are there kind of pre-bail. And many of them, again, 61%, according to HBD, is mental health or substance use. So if we took those resources and put them into the behavioral health, mental health, and substance use and get folks the help they need, then we would actually save a lot of money, too, on the public safety side.
It's not really so much as, hey, we don't have the money. It's that we need to reallocate the huge amounts of money we're spending, and if we don't, it's growing every year. It's going to be a crisis.
Speaking of, here's some questions from some of the viewers relating to that. This is one from Nikos. Is the state utilizing all available federal funding for community-based medical treatment for, say, these types of conditions? Is it being utilized? Is it being used? Or are there roadblocks? Well,
the money that is known to be available, I believe that we are, by and large, using that very well and using it very efficiently. I don't think it's very much. I suspect that there's funding available out there that we don't know about. I mean, I think for prevention, they say across the nation that the Department of Agriculture is the biggest funding source for drug prevention, and who knew that? And are we tapping into that? We don't know. So I'm sure there's resources we're not tapping into, but it's really can come down to reforming Medicaid and reforming insurance and better use of the dollars on there, and then using the state funds to supplement it and tie it in.
I think we had some another slide on that too, by the way, as far as treatment among the uninsured, and part of the problem here in the state, because with a larger meth problem here, and a lot of the individuals who are addicted to meth are the ones that don't have insurance, then therefore creating a bigger problem. I think this is a slide that we have here. 51% are referring to methamphetamine, far above what other people come in for as far as addictions or types of.
That's really
use.
true. Most of the people that we've seen on methamphetamine come in, they don't have insurance.
Yeah.
They can't fill out the forms.
Yeah, and that's what we're seeing in drug court as well. No insurance, and the need is just so high to treat these people who are really in need. But we don't have the money, and we don't have the resources, and we have the networks, but the networks are overloaded right now. Every day I hear about Hinamaka. Every day we network with Sand Island and Poilani and all these other treatment facilities, and we know that they are packed.
With long wait lists.
Yeah.
I think another part of that that's probably important to talk about is because there's limited resources to get treatment, especially for the people who don't have insurance or some way to pay. They overload the emergency rooms and EMS because it's the only avenue their access to health care.
Yeah. Yeah, you hear a lot about that through the medical facilities as well, through EMS, where it's just, and repeatedly, I would imagine, I'm sure there are quite a few people that you see on a somewhat regular basis, or that you're familiar with their faces.
Yeah, we do. We have a long list of people that we've termed hyper users between the hospitals and us that we talk about, and the vast majority of them, that when you look at that list and try and look at them case by case to try and figure out why are these people using EMS and utilizing healthcare through the emergency room so often, the vast majority of them have some sort of addiction or addiction compounding problem that relates to that.
You see this, and your colleagues see this day in and day out, whether it's specifically related to a particular type of opioid or some other type of addiction. When you're dealing with these people in this state, how often do you feel that they're in a desperate situation, or they are in the throes of an addiction that they do not want to let go of?
I think from speaking as a paramedic, you see everything in between. You see people at the early stages. You see people who've had they experimented one time, they had an accident, and maybe they learned their lesson, to the chronic person, all the way up literally to to someone who's overdosed and died, and we're trying to resuscitate them. And you see every phase of that, on a daily basis, unfortunately.
That's got to be tough.
We saw a big difference we always had a wait list at Hinamaka, so you have 5 to 10 people on the wait list, and we started stepping into helping you with your depression, your PTSD, and then we said, we'll help you if you have diabetes and if you have a heart disease. And all of a sudden we're flooded, 40 to 140 people on the wait list. And most of them are coming not because they want to let go of their addiction. They're coming because they can't get help for their pain, their diabetes, their heart condition, and they're saying, please help me, because no one will help me because I have an addiction. I know I have to do that so I can get help for my medical condition. And so that's a big difference. People willingly wanting to get help for this and willing to get treatment. Otherwise, I don't think people were saying, I'll wake up this morning and go, I think I'll come off my opioids today. And how hard that is. It's not
and that stigma or that categorization within our society and within maybe lawmakers in some case, that really is a big push for a lot of you that are working at the ground level and dealing with folks, as far as changing that categorization today, knowing what we understand and what it's going to take to get the kind of support and resources and change in how we see all this.
You're completely right. Research says that stigma is the #1 barrier to substance use treatment, because people are afraid to talk about it until it becomes overwhelming and chaotic. Folks often have that moralizing of, if you just take care of it, just pull yourself up, just stop. And what we know is that it's a health condition, it's a public health issue. Relapse is part of that, and so when we have it from that framework, we can really treat. For example, if someone had diabetes and they were on insulin and still ate some sugar, you wouldn't be taking away their insulin and shaming and blaming them for struggling. You would say, okay, how can we help you change your behavior and become healthier? The same thing with substance use. Folks are struggling with their substance use, may want to make changes, but it takes a while to get the support, the motivational enhancement, and getting into treatment. And so we really want to fight the stigma, because again, research says that's a #1 barrier to treatment, in addition to the money.
A couple of questions for you, Judge Kubo, talking about all the work that you've been doing with Veteran Treatments Court and what's available through that or through the VA. I think I would imagine we have some veterans watching right now who want to learn more about it or maybe are afraid to take that step in that direction.
Our Veterans Treatment Court networks with the VA, and what we do is we have them go up to the VA for their treatment. We will house them at the U.S. Vets or Oxford Housing or other locations. And the VA or the federal government will pay for their treatment, their services, and everything else. However, there's people who do not qualify for VA, who have served our country, but for one reason or another did not get the honorable discharge. But yet they put their lives in harm's way as well for our freedoms. So we will take them on as well. And we will work with Hinamalka and them. We will work with the other providers. And it will come out of the state probation office funding. And so we work in tandem with many people, not only with VA. But at the end of the day, most of the veterans come into our program homeless and without a job. Everybody graduates with a job and shelter. And we have 0 recidivism rate.
That's
so
incredible.
We're one of the top 10 in the nation right now. And we currently have roughly 25 people in our program. By the way, the next one is going to be graduating tomorrow in my courtroom.
Congratulations to them.
He's a great guy. And I'm sure he'll go on and do bigger and better things.
Well, we work together really well, and when we do, we're really effective. So these collaborations among all 4 of us here of helping each other, we really make a big difference when we do work together. And so we have great outcomes when we do. It's just that we're dealing with a small part of the problem because there isn't very many of us to do this.
So we're going to talk a little bit more about some of the solutions and some of the other programs that you guys are working on. But I wanted to take a little bit of a step back with some of the current news that we have right now with President Trump making an announcement saying that the opioid situation is a public health emergency as opposed to a national crisis. So what does that mean for either the nation, for here in the state? I know a big part of it is just to get the funding necessary to be able to support some of these programs. Have you seen any of that money coming down? Are you expecting it? What's the situation in regards to that?
Hawaii did get $2 million in what's called opioid state targeted response. Every state got money. So we got $2 million for this year and $2 million for next year. It came to the Department of Health, Alcohol and Drug Abuse Division. And it is slowly getting out into the community. I believe Hawaii Substance Abuse Coalition is getting some for training. We've already gotten some naloxone, which is the overdose antidote, and gotten that out to law enforcement already. So it is getting into the state, and there now is an opioid strategic planning process that's happening at the state level that is convening folks like Alan and law enforcement to come together and have recommendations on how to use those dollars and move forward.
But that was different, though. You know, that funding was set up by U.S. Congress because,
that wasn't.
And we've said jokingly the last couple of years that the only thing that Republicans and Democrats at U.S. Congress agree on is that we should do something about drug addiction, and they release money. And so they're saying, hey, the science is available, we can make a difference, let's do something. And so we've been getting some money from them. Now, when President Trump made it if he had made it a national emergency, then money would have been available immediately. But making it a public health, money is not available immediately. And it has to go through channels, and it'll be a lot less money, but it'll still be, so support. But it'll be a lot more planning and what we're going to do with it, and then we're waiting for Congress then to fund it, which it looks like Congress is very interested in doing that. So it seems like everyone's united on that we need to make changes in this area. It's that because people are suffering, and because I think it's becoming a middle class problem, and it's also because it's too expensive not to. So those are good things. We would have preferred the national emergency, though, because then that would have been immediate relief.
And people are dying every 9 minutes in the United States. Somebody dies of an opioid overdose. So that's the other kind of mitigating piece, is why there's not more money. The public health emergency does allow some streamlining of policies and allows some access to things like increasing Suboxone and making it easier for law enforcement to have naloxone. So there are some policy supports from the public health emergency, but no dollars yet.
Well, you know, they are encouraging planning, and some of the money as a public health is saying, let's do some planning. And we're now meeting on task forces. There must be 90 of us in there from hospitals and providers and state people and law enforcement and judges. And we've never had all of us in one room like that together talking about what we have to do something together.
You mentioned Narcan, by the way. I think we have a slide on that. That's something that this is only fairly recent, or how long has it been since you've been able to say paramedics in a broader scope of responders have been able to use that when they feel it's necessary? Is that fairly recent?
No, paramedics and hospitals have carried Narcan for decades. It's been the known antidote for it only works specifically on opium and its derivatives. It's been over since really the rise of the opioid crisis. You've seen really starting from the East Coast.
I think the doses we're seeing on the screen, the doses have actually gone down a little bit here in Honolulu in particular.
Correct. We haven't seen the big opioid spike that they've seen in parts of the mainland. Now we're worried that it may come at some point, but so far we haven't seen it. So what you're seeing there in that slide that we were talking about is the actual number of doses that paramedics have given to people in the back of ambulances, so that they may have suspected an opioid overdose, or in some patients they need multiple doses, to get an effective dose to alleviate the effects of the opium.
Well, we're definitely behind. We're way behind the nation in terms of how much of an opioid and heroin crisis that's happening. But though we believe we're on the cusp of one, because if you look at the data, we do see this huge overprescribing. And so, I mean, we're talking half a million pills going out. So we think we're at the cusp of that kind of a crisis.
I think we have a related slide on that, by the way.
But I think on that note, and to what she was saying, is that I think preparations are underway, and we sense something coming. The work that they've done with getting law enforcement to be able to carry Narcan.
Drug poisoning fatality rates, by the way, as you can see there, United States significantly higher overall, but Hawaii still, it was up, about to 2005, 2006 or so. It was following the same trajectory, and then it started to level off, or I mean, not necessarily get better. It's still increasing, but not nearly as much.
Well, unless something really changes a lot, it looks like we're going to have a crisis, but we're not going to have any kind of a crisis that they're having like in the Northeast, or with the heroin and the big problems they're having there.
We're not seeing it.
I think we're seeing methamphetamine being very strong here and marijuana being so strong here. I just don't think we're going to get to that heroin crisis.
And that's what we're seeing in the courts right now, because I would say that 90% of all our cases are still methamphetamine. The other 10% is split between opioids and cocaine and marijuana and the other.
And again, do you think that's because it's more inexpensive or more accessible? Why is that still, methamphetamine in particular, have such a grip here?
Easier to make.
Easier to make.
It's real easy to make.
So you would think then that it would be as widely, you'd see the same spikes on the mainland. Is it just that they've had more access to these other types of medications?
Well, yeah, I think they had pill mills, especially in the Northeast, and then through down to the South. So you had these huge pill mills, and then some of the retail stores got into dispensing opioids just right over the counter, and we just didn't have that here, and so that really led to it. And speculation is also, we're not sure, but speculation also is we're a very smokable culture here. We're not that injectable culture here.
So that's shifted. So last year alone, in Hawaii, over 1 million syringes were exchanged at the statewide syringe exchange, which is up significantly than over past years. But you're right, though. Historically, there wasn't kind of new cohorts, and in the past 5 years, seen a lot of data that people have started to inject that we never saw before. And ice injection actually is up in Hawaii, which is really scary because that is a new thing that we're seeing.
And heroin's up to 5% now, the people in treatment, and that's, we've never seen heroin hardly at all here in Hawaii. Now it's 5%. That's a big increase in the last couple of years. Not huge numbers, but how quickly it grew was nervous.
I'm
But
sorry,
you
Judge
know,
Gaddard,
it is
interrupt
the Coke, the Pepsi, and whatever is cheaper, you will drift towards. And so far, you know, ice is still the cheapest one around. Although I do see an uptick, not significant yet, in the courts of opioids.
Let me get to some of these questions. This is an interesting take. This is from Lloyd in Wiley area. Once a person is addicted to opioids or to meth, can they be quote unquote cured, or will they have lifetime symptoms? I don't think I've heard it asked quite that way before.
You can never be cured. I see situations where people think that they are cured and they go back to the old neighborhood, or they go back to their old habits, and they pick up where they left off.
And I think this really has to do with what you're talking about treating all the factors that led to this stage in their life, or this crisis in their lives. It's not just one thing.
Oh yes, traumas, everything. Although I would say medically, according to ASAM and the DSM-4, the DSM-5 we shifted to was just to say, hey, we really need to look at substance use disorders as this whole gamut of, you're here, you're abusing, it's harmful to you. Could you slow down, and could you, a harm reduction process, and then could you be okay? Yes, you could. If, when you start getting to Hinamauka and drug court, you're coming to an addiction process, and you're going to say, once you reach the stage of a full-blown addiction, then we would say, hey, you need a life of abstinence, because if you start again, you will return back to that. Now, will you recover and lose your symptoms? Yeah, you could recover and have a great life in recovery, but you have to be careful that you don't return to these type of drugs again, because then you could start your addiction again. But if you're abuse, no, that's not true.
So knowing this, Judge, with the zero recidivism you're getting right now, what are you doing, you think, that is working in that way for these individuals, these veterans who are dealing with a crisis themselves? What's the difference?
We use their method, and that is you teach them the tools to survive. You teach them how to...
It's not just about the addiction, it's about life.
Yeah, it's about a total life change. Veterans Treatment Court has the use of what we call veteran mentors, who are people who have served in the military, and they act as big brothers, big sisters to the defendants in court before me. These defendants are required to stay in touch with their mentors. They come to court every week. They see their counselors every week. We keep them busy in terms of clean and sober lifestyle. We teach them how to stay away from or to practice safe boundaries. And when they do this day in and day out, then they can start changing their life. And that's the key to recovery. And you add on the fact that these are military, so they are used to structure and discipline that the military provided them. That's the key to success.
Okay, I've got some interesting questions I've got to get to, and this is a little bit all over the board, so bear with me. This is what opioid problem due to medical physicians writing excessive prescriptions. This is from Bird. Do you guys agree with that is an issue, or is that kind of more of a sidebar?
Oh no, it's definitely an issue. And here in Hawaii, we have something called the Prescription Drug Monitoring Program. Okay. And that is the way that Narcotics Enforcement Division and other folks look at when someone gets an opioid prescription. You're supposed to look them up to see, do they have a lot of prescriptions, or is a doctor overdoing that? So there is, in Hawaii particularly, our folks are looking at that issue. And now there is on the continent, some doctors have gotten arrested for even manslaughter because their folks have overdosed on the prescriptions that they've given them. So we are seeing more accountability.
That's part of the plan, is to get that program out. As we don't see a lot of doctors using that, but it's now available. But that's going to happen over the next few years, so that before a doctor can prescribe, they have to look it up to say,
So that's coming. That's going to strengthen. Okay, here's another one. This is from Larry. Here's another interesting one. Could medical marijuana prevent the use of opioids?
There's actually a lot of evidence that medical cannabis does reduce opioids.
Really?
In fact, in states that have medical
question, Larry.
cannabis, there's actually lower overdose rates. And there are a couple pain doctors in Hawaii specifically. Dr. Miskovich is one of them who said that his data indicates that he's been able to get quite a few folks off of opioids for medical cannabis.
Okay.
So
That's
there is
discussion.
a lot of evidence in the literature about that.
How about
The issue, though, just to, we're going to not agree always on
That's
things.
fine. Now.
But what we would say is that, a lot of now that we're having medical marijuana, we're actually doing research for the first time. And so we say, there's some cannabinoids, there's some CBD in marijuana that are now being considered a wonder drug and that has tremendous medical benefits. Now we're also looking at THC as being, that you can get high on, that's looking to be very, very toxic. So all the research is kind of breaking that apart to say, you know what, we were wrong about medical marijuana. There's some things there that are wonderful and we should start harvesting that, and maybe it comes into a pill form. The THC part that you get high on, that looks like that hurts your brain, that causes addiction, and maybe someday the community is going to make it a recreational drug and we can say that's not the medical marijuana part. And so there's a lot more research needs to be done there, but the research indicating so far, it's a lot different than we thought it was. It's not, there's some really good parts to it.
Okay, I'm jumping around, I know, but I want to get to what our viewers are asking about. Pill parties. I don't know if maybe sometimes, I don't know if that's something that you can pick up when your guys are out in the field or not. Are you still seeing that? Is that a problem, or is that more of a kind of a trend that kind of came and went? It's Don from the New Times.
I'm not aware of any specifically here on Oahu, but anecdotally, you are hearing about them still across the country.
Still available, too much available.
I hear of them, and we're about to get the updated youth risk behavior survey data, which is actually asking specifically in both middle school and high school youth in Hawaii, did you use a pain pill without a prescription? So we'll be getting that data very soon to help indicate that. The snapshot I saw is that was more than I was expecting.
More than you're expecting. Responsibility of drug companies on this issue. I think we touched on this early on. At this point, I think there's a bunch of lawsuits out there regarding how they market. Is that anything that's being addressed here locally? I don't know or if that's more of a, I'm sure on a national level that's being discussed.
Our Attorney General signed on to one of the lawsuits against...
I think it's more of like a class action type suit where they're joining a national thing. A lot of people are talking like it's going to be with like the tobacco industry, where they go and these pharmaceuticals have to pay each state a large sum of money for
that really is a good
for misbehaving.
That is a good comparison.
Yes,
that is a really good comparison, because I think for tobacco, for the longest time, by doctors, the community was considered generally safe, and that's the way that it was marketed, and everybody thought it was safe. Same thing with prescription medication. Well, doctors are, like you said, Heather, are prescribing it, and so it's okay. This is from Anna, and he said, "Why is alcohol socially accepted when that is also a major addictive drug?" That makes me think too. It's generally considered socially accepted. In this context, and so then therefore it continues to be a problem. Same thing with prescriptions. It's still
I believe that we have more science today that we could do a better job.
True.
When we start looking at marijuana and say, okay, we're going to legalize that, and it's less harmful as others, but there's a toxic part. Maybe we could do better than what we did with alcohol, and we could get message out to the kids. We could do some prevention things. Hey, it does look like if kids abuse marijuana, they lose IQ permanently, and that's a really alarming thing. It looks like if adults misuse marijuana, they lose IQ, but they get it back when they stop. So, we just need to have better science, better messages, get rid of the myths. There's myths on both sides of this equation. Let's get to what's really true, and let's present it for whatever it is. And society will just choose whether they want to legalize this or that, but let's talk about what's real and what's harmful and what's okay. And moderate use, maybe okay.
At least a few questions from folks on some of the neighbor islands asking about whether it's referring to the drug treatment programs of the courts or the programs that you guys are dealing with. What's available on the neighbor islands? And is it enough? Is that a problem? What's the situation? I mean, we talk so much about what's happening here on Oahu and in Honolulu. Neighbor islands, let's talk about that.
Residential treatment is a
big problem on the areas that, in those rural areas, there's just not enough services.
This is from Kona, this is from Pahoa.
There's not comprehensive services. There's not residential, and only Maui and Oahu, and only one on Maui, and no residential services on the others. And outpatient is really tiny on the others. And There's some really good people on each island doing a good job, but they don't have resources and they don't have psychiatrists, psychologists, support people.
How about for EMS? Is it even more strapped on some of the neighbor islands? I would imagine statewide it's an issue.
Yeah, statewide it's an issue.
Just having bodies to.
Yeah, I know the Big Island's been in line, and we've, collectively the EMS across the state has been trying to support getting additional resources for Kauai, for the Big Island, and here for Oahu. Specifically those three, all the islands could use more resources.
Yeah.
There is a drug court on each island.
There is.
But we're only as strong as the people we network, and if there's not enough drug treatment programs on the island, it takes a longer while to get them treated.
Is it tougher to reach them?
Many times they have to come to Honolulu to get their treatment. Now that's a hardship, and so it just boils down to the same thing: money, money, money.
I think we had a couple slides up. I don't know if you guys still have that. We were showing Maui that at one point they spiked particularly high on Maui, and I'm not quite sure. There it is. This was in 2012 to 2016. What were you hearing in particular about why on the Valley Isle the numbers got so high there? Was it the population? Was it the more of a middle class kind of a problem that stood out?
I really don't know, but if you're talking about opioids, it just probably means maybe they had more doctors per population than say Kauai or Big Island, where there's such a huge shortage of doctors.
Yeah.
And we don't know. I would say that we're spending huge dollars by not doing enough about this. And when we start to treat it as something that's urgent, an emergency, and having good, recovery strategies, the gamut of them, that we could really make a huge difference here. Not only in the numbers and the people that we're having problems and the suffering that it goes with in the families, but the dollars are huge too, what could be saved.
This is, of course, all of you are dealing with this. What can be done? We've been talking about it to some extent. We didn't talk about some of the programs that you're involved in and some of the ones that are coming up.
Yeah, so earlier we talked about law enforcement assisted diversion, or LEAD, which is going to be happening hopefully by the beginning of next year. Yeah, so it's brand new. $200,000 was in the governor's budget allocated. It's an evidence-based or promising evidence-based practice from the continent. There's now almost 70 jurisdictions. The thought is that for folks that have low-level offenses, then police officers could be another portal into services. So if a law enforcement officer, our pilot's going to be in Chinatown, comes across somebody who has a low-level drug offense or a homeless offense, and they don't have any kind of violence or other concerns, the law enforcement officer can then do a warm handoff to an outreach worker within 20 minutes, and then that outreach worker can work with them, and they have to do an intake and then get case management that diverts them out of the system. So we're really excited about that pilot coming up beginning next year.
And this is what a lot of you are involved in closing the gap in time and how quickly people get some level of support. I would imagine that can be absolutely critical for a lot of the people you're dealing with. Different ways that close that gap in support or response.
Well, we are, the governor's task force and just healthcare reform in general brought us all together that say, hey, we could, we don't have to just wait for the federal government to do this. We could do a lot of reform here. And that's created a wonderful energy. Yeah, more resources are needed, but we're all talking to each other, which we've never done before. There's outreach now, which there really hardly was any outreach before. There's case management to help you connect with services, and those, we're just starting them. But so there's a tremendous amount of hope here because we're doing things collaboratively that we didn't do before. The emergency room wants to have us be on their quality assurance committees. We want to deal with addiction inside the hospitals. I mean, it's just really changing that we're all talking to each other. And I think good things are going to come out of it. And hopefully we'll be able to say, too, resources need to come, too, because we can do something. But we have a stronger voice when we all talk together.
Yeah, my outreach workers are going out with police officers in Chinatown together. That kind of public health, public safety partnerships to really be able to have a unified front. Like, you're right, we're working in ways that we never have before. It's a really exciting time to see everybody coming together. It's a complex problem, so we need complex solutions, and we need all of us to work together. And it's exciting to see kind of these non-traditional allies come together and say, hey, we can work on this issue together.
We never had law enforcement come and say, could you help me with this?
Yeah, and they do.
Oh, it's like, wow.
See, this is, I want to get to a slide here that we have too, just kind of dispelling again sort of some of the myths that we have as to who the population is that we're dealing with. And this talks about, I think a lot of people think, oh gosh, if they're a drug addict, they're shooting up somewhere out on the street, and they're under a bridge somewhere. But this really is in our communities, and I think one of the stats there is 86% of the victims are found inside a house or apartment. So these are family members, people within the community, oftentimes, that I'm sure you're seeing. There isn't the separation that we want to imagine.
It's not them, it's us. I mean, honestly, it's our brothers, our sisters, our aunties. Everybody's affected by addiction. That's what the data says. And what's about the overdose piece, we really want to encourage folks to learn about naloxone. So sorry to do a quick plug, but we have a free naloxone program. So if you go to chowproject.org, you can learn. If anybody in your life is struggling with opioid use, call us, come in, we'll teach you how to have this life-saving medication that, gosh forbid, that happens in your community or in your home, you'll have this naloxone to save a life. And what we're seeing now is prescribers or folks like EMS, law enforcement carry it as well, so that no one has to die because we'll have this amazing life-saving medicine.
That closing of time.
And it works specifically with opiates, right? Because it drops the respiratory drive. So someone to have the ability to breathe for the person. So, they also need to learn CPR. Is probably another.
Thank you. And rescue breathing. Thank you.
And rescue breathing, is just as important, if not more important, than the ability to give naloxone or call us so we can come and give them naloxone to reverse the opiate.
Judge, I would think that with the programs that you're involved in, as well as the drug court and the veteran program, just the success of those programs has got to be some of the most powerful things as far as advocating for more money and resources. I mean, just showing what you can do.
Yeah, but for example, drug court is a 2-year program. So that's something that is an investment by the judiciary, which works because we are kind of like an IOP program or an outpatient program. We have our own counselors, we have our own probation officers who are specialized in this area. They're trained, and we accept people at their lowest period in time. But networking sometimes, like we were discussing earlier, can kill the fight, especially when it's a long wait list. There are places that it will take 6 months being on a wait list before you're accepted into that program. And by that time, kill fight. The need to want to be cured or want to recover has gone 4 months ago.
I really wanted to make sure I got this question in from Franny. She says, how can community members make meaningful contributions to start healing our island communities? There's people out there that want to help you who are helping people. Do other communities have successful programs that you've seen elsewhere that might work in Hawaii?
I think the biggest thing community can do is when we change how we think about, talk about, and act about addiction, to remove the stigma of that. When the community starts seeing it as something more than something highly stigmatized, the old idea that, oh, you misbehaved when you were young and now you have an addiction. And as soon as we dispel with that kind of thinking, that's the biggest thing the community could do. And I really believe we're not going to solve this problem at all or make a big dent until the community joins in that and does just that.
And break this. Oh, sorry. Go ahead, Judge.
One of the things that my court is starting to do is to bring in family members as a support mechanism that aids in the recovery of the individual.
They need help too.
Yeah, and the family grieves. It's a grieving process for the mother or the father or whoever it is that's affected, that's close by the person who is addicted. Sometimes they'll dime them out. In court, they'll say, this weekend he was using, or he wasn't checking in. But most of the time, they're there, and the family comes together during this recovery process, and the family somehow, you can see them, the love growing again, and they're moving on. And many times during our drug court graduations, The families are all there, and it's like in high school. You know, and there are hugs and crying and kisses and children and toddlers and babies there, and it's really a cool thing.
The American Society of Addiction Medicine, you know, the leading, you know, doctors about addiction, just released a report last week that said that according to their study, 46% of Americans have a family member or a friend who has an addiction.
46%.
6%, or an abuse, addiction or abuse. That's a huge number. And we would say, we often tell the families, well, come in and let us talk with you too. And they go, no, I'm fine. I just want you to help my family member. We go, of course you're hurting. You know, if your loved one is going through this much suffering, of course that's affected you. And you feel betrayed, you feel hurt, you feel left out, you feel isolated. You need some help too.
That's the way you put it, Heather. You said it's not them, it's us.
Yeah. And to break the silence, that's exactly what I think our community can do, is have these conversations like today. We're very thankful for PBS. But if 46%, if half of us have a family member, talk about it. Break that stigma by having conversations, normalizing talking about substance use disorder, so that it's not the bad thing that's hidden away in the closet and, oh, that's just their issue, or we're gonna, you know, hide it away. That really, it's like any other health issue that we would discuss and address.
Yeah, Chris, you're out there. You can't always identify whether it's an overdose, but you see the trauma, the scenes that you go to, how traumatizing it is to the family. Well, thank you so much, all of you. You know, we can never get to quite everything, but it's just to get this back on people's minds and to realize that it's all of us here that need to deal with this. Thank you so much for being here and for your insight and for all of your hard work in helping the community try and get a little bit safer and help their families. So we want to thank all of you who have joined us tonight. Again, special mahalo to Judge Ed Kubo, Hawaii State Circuit Court, Heather Lusk with the Community Health Outreach Work to Prevent AIDS Project, Alan Johnson from Hinamauka, and Chris Sloman from the City and County of Honolulu Emergency Medical Services. Thanks again to all of you.
Thank you very much.
All right, Insights. We'll be back in 2 weeks with another important topic, a subject that seems to be even more of a problem around the holidays: domestic abuse. How can we all be better informed about how to respond and prevent these incidents of violence? That's in 2 weeks from tonight. I'm Laurie Amata. From all of us here at PBS Hawaii, we wish you a wonderful Thanksgiving. A hui hou.